Hello and welcome to the Musella Foundation Brain Tumor Webinar Series. Today's special guest speaker is Dr. Nick Butowski, Professor of Neurological Surgery and Director of Translational Research in Neuro-Oncology at the University of California, San Francisco. As I mentioned, we will have a Q&A at the end of Dr. Butowski's presentation, so please feel free to type your questions into the chat. Dr. Butowski, thank you for joining us.
My pleasure. Thanks for inviting me to be here tonight. Just as a reminder to folks listening, I can't really see you, so I'm happy to take questions at the end. And I'm just getting out of clinic, so my brain might be a bit scrambled as well. So forgive me if I go off script, so to speak. But I'm here to talk about integrative medicine approaches for patients with primary CNS tumors. And much of what I'm going to talk about tonight applies kind of across cancer, if you will, in general, and across integrative medicine. And often the answer to the question of whether a certain patient should use it, the answer is it depends, and is something you should discuss with your primary neuro-oncologist or oncologist. But with that warning or caution, we'll get started. So I have no disclosures or support as regards most of the topics that we're discussing. I do have some NIH funding to study the ketogenic diet, but nobody's selling that, so to speak. And so what is integrative medicine? So there's going to be some terminology thrown about tonight that maybe it's good to get on the same page about. In essence, there can be some tension between what I'd call traditional or complementary and integrative medicine. Essentially, integrative medicine fosters a relationship between all those involved in the patient's care with optimal alignment, if you will, of physical, mental, emotional, social, and spiritual aspects of health. I'd say it emphasizes the whole person, right, including analysis of all of what I mentioned, but that also includes physical, nutritional, environmental, and like I said, the emotional, social, spiritual aspects of life, including lifestyle values to achieve both health span and lifespan, right? So other terms thrown about here are allopathy, which uses drugs, sometimes surgery to treat ailments, while homeopathy works on improving the body's response to disease. I mean, I think you can do everything if you're a good physician, but integrative oncology is kind of all of the above, right? And we'll go into a little bit more details in future slides. At UCSF, we're lucky to have the Osher Center for Integrative Health, which really focuses on some of those aspects that I just mentioned. And you can have a consult there if you're part of the care team here. And that Osher Collaborative for Integrative Health is around the world, and these programs are meant to study these types of things and how they are related to not only oncology care and brain tumor care, but in the setting of all healthcare, right? And this is a healthcare concern, not just for the obvious, but actually more for the fact that the discussion between patient and physician regarding the things we're going to go over today and beyond is often not mentioned in an oncology visit. And therefore, you put yourself patient-wise at risk and physician-wise at not providing care to the patient when you don't communicate about the things that one would include integrated medicine care, right? So patients, providers do need to bring all of that to their mutual attention so as to not engage in potential harmful interactions, if you will, and as importantly, lost opportunities to recommend potentially helpful evidence-based therapies that can help along the patient cancer's journey. And it's not like we're talking about foreign substances here, so to speak, right? These types of things, whether acupuncture, massage, or what have you, all the things we'll review today and again beyond, are in part of our daily part of our guidelines, as they are from big societies like the American Society of Clinical Oncology, which is the largest oncology society, and the Society for Integrative Oncology as well, right? So you can, if you go to those websites, guidelines in terms of what you can do, both from a patient and physician perspective, do exist and can give you guidance. Beyond that, like I said, at UCSF, we also put some of these into the different domains seen on this slide, whether they're directly part of the oncology care or caregiver program or what have you, social work, palliative care. they all, somebody does it, right? Somebody's here to guide you. And different physicians will have different levels of sophistication, comfortability, what have you, on them. But along your journey in these venues, you can ask always and see what they think and what guidance you think is important. This slide's really just to demonstrate how perhaps my inarticulate speech thus far can go into different sort of if you will, rabbit holes, right? Again, based on terminology, based on where the patient or the physician is putting emphasis. But these are the core components represented in different ways, right? For evidence-informed patient-centered care, where, you can say there are, in my opinion, lifestyle modifications, mind-body practices, and natural products is where I think most of that discussion about integrative care comes into play from a simplicity perspective, and how they also dovetail into how you can talk about it. Where's your MD coming at it from? Where's your integrative oncology coming from? Where's your naturopathic doctor coming from? And where they meet, if you will. So with that preamble, we'll jump into some specific topics. And the first lifestyle modification is diet. I mean, everybody asks about diet, and I don't know what advice each individual gets. I think it's probably all over the place. And I tell patients the right diet is the diet that works for you, right? In essence, there are many things that you can try, which is going to lead to improved health span and lifespan really does depend on your specific situation. But the rationale for looking into this is known, right? Diet and obesity are critical factors sometimes in cancer, although not directly necessarily related to the cause of brain cancer. But a balanced diet can manage inflammation and is a key component to feeling good, right? And to survivorship. So strategies, I mean, in essence, a plant-based diet is always recommended, right? It's low on inflammation, can be low in calories. Getting nutrients from whole foods is thought to be better than pills for absorption, and because in combination, those molecules can work better at fighting disease than they can alone. Ketogenic diet, which is a low carbohydrate diet, high fat diet, exploits what's called the Warburg effect and the metabolic weakness evident in some tumor cells. Studies in glioma do show potential benefit for this, but it's very difficult to do with it. Frankly speaking, I think it's impossible to do without a nutritionist or dietitian along the way. And it is socially isolated because, of course, your family's generally and your friends are generally not eating the same diet. So it takes a lot of work. We do have a study in newly diagnosed GBM to look at this and whether or not it does provide benefit. I'm not sure what's going to happen. There is a society meeting about this in Paris in September, which is great because it's gaining more focus around the world. But I don't think we're going to know the answer to whether a ketogenic diet works, so to speak, to fight brain tumors in a black and white way for some time. And we may never know, because of course the heterogeneity amongst patients and disease is quite high. We'll talk about supplements and antioxidants and how they can be put into the diet a variety of times throughout tonight's talk. But the effects of antioxidants are complex, right? And again, how you're ingesting them, what company you're buying your products from, all makes probably a crucial difference in terms of how these are potentially providing benefit or potentially interacting with chemotherapy. And again, I would encourage you highly to discuss those with your doc. I always put or guide patients to look, let's do a nutrition consult. Let's avoid deficiencies. Let's bring to the forefront the surprising things you probably don't or are not aware of in your own diet when you start to pay attention and you use something like an app like MyFitnessPal or something to oh, wow, my diet's not as good as I thought it was, or is worse in a way that I wasn't really aware of. I think those are important things to know. And if you do that with your physician or yourself or a dietitian, like I said, you can come up with achievable goals, which generally include what kind of diet you want to eat, but also an ideal weight. You can do that through meal services that exist, and I don't have a formal relationship with any of them, but methodology and the like can provide really good meals, whether you're going keto or what have you. And then I tell patients, look, read this book, How Not to Die by Mike Greger. It's going to give you the evidence. It's going to give you much more detail than I can go into tonight about why you should eat well, so to speak. And again, whole plant, mostly fruits and vegetables, little animal product because of the inflammation. But it'll give you more data about like, is going vegan right for you, right? Because in the strategy of talking to patients, you can easily say, hey, look, vegan's better than vegetarian, which is better than pescatarian, which is better than flexitarian, which is better than eating whatever. And based on inflammatory, measures, if you will. But if you're a vegan that eats potato chips all the time, right, then that's probably not right. So it is, again, the right diet is the diet that works for you. I personally would, in my own life, minimize red meat, processed meat, and sugar and alcohol. And I get what I can from whole foods. I think that's important for everybody to feel good, to fight off the things that chemotherapy and what have you might do to your gut. I think probiotics are important for gut health and perhaps beyond. Which ones are difficult to say, to be honest with you. And I think there are different sources that you can get them from, whether kombucha or yogurt or pills. I don't think it matters. I think there are more or less reputable sources out there that you can get on AI or Google and search these days. But I do think those are important. But again, this book is a real good compendium that'll give you the data that you need to make up your own mind. But that there's no real evidence within the brain tumor land that any specific diet at present is going to lead to a better outcome, if you will. And like I said, studies are ongoing for ketogenic diet's role. I think that's important, but I think what might be important is fuel utilization. And what I mean by that is your glucose, your blood glucose level for everybody, regardless of whether you have a brain tumor or not, is probably important for how long you live as a one important factor, not the important factor. But having a blood glucose that's on the lower end of normal more of the time is probably the most important thing in assuring both health span and lifespan. That's my guess. I don't know that for sure. And if you listen to podcasts from Peter Attia and The Drive or the like, Rhonda Patrick and such, they can go into that in greater detail than I'm going to go into tonight. But I think that's where the science thus far points to. But again, I could be wrong, and this book will give you much more data than I can at present. Other lifestyle modifications and integrated medicine practices or exercise and physical activity. I don't think this is going to come as a surprise to anybody. The American Cancer Society advises patients to pursue at least 150 minutes of moderate to intense exercise. I think both cardiac exercise is important. It boosts your immune system, but if you can, weightlifting is also important. Resistance strength training for both bone health and overall health. They, say grip strength, foot strength, and how much you can squat are actually independent factors of how long you live. I don't think that changes just because you have a brain tumor, and in fact, probably becomes more important. So you focus obviously your exercise plan on those types of things. But obviously, our patients face neurologic and musculoskeletal problems in achieving those goals. So working with an exercise professional can help get you there. There are a variety of programs offered at UCSF and beyond to achieve your goals. And whether it's Pilates, where you're on a machine that can minimize gravity and isolate muscles, the non-glory muscles, so to speak, or water-based, where you're not worried about falling. Those are really important. I think wearables like your Apple Watch or what have you, and making sure you're getting in enough steps and making sure you're hitting the different zones of exercise are important metrics that can help you achieve your goals. But again, just like with the diet, perhaps visiting with an exercise physiologist at the very least, discussing with your oncologist about what should your goals be, how can you achieve them is an important part of coming up with a strategy that is peculiar to you. And, getting into maybe new routines and making it social is never a bad thing either, so that it's right and enjoyable for you. Sleep is very important and something I review with every patient. It's important for both health span and lifespan, right? So, in essence, in our patient population, both from brain injury and anxiety and other issues, insomnia is prevalent. And again, multiple causes go into that. Often, the best way to manage that is sleep hygiene, right? You want to go to bed at the same time, roughly, get up at the same time. If you're going to nap, nap at the same time of day for the same amount of time, generally less than 30 minutes. Gets you the good type of sleep that you need. And if you need help beyond that and paying attention, it's cool room, dark room, again, making your bedroom and where you sleep a place of relaxation. If you wake up from insomnia and anxiety, engaging in strategies that battle that. And that's either cognitive behavioral therapy I, which is insomnia, which can be found on apps or websites like Muna Health, or engaging in practices like yoga nidra, which is not yoga in the traditional sense. You're not moving, but it's relaxation, body scan kinds of practices that help you get into deeper states of sleep. I'm not big on medicine for helping patients sleep. Once you address those issues I've mentioned, often 99% of the time, patients improve their sleep to where they'd like to be. But if you did need medication, magnesium and melatonin are used fairly routinely. I think magnesium is the most benign, if you will, and often can help relax your nervous system to help you just get that, over the finish line, if you will, of good sleep. Melatonin, never know quite what you're getting in terms of how it's processed, and there's been some back and forth science about its true improvement. Cannabis we'll talk about later in the talk. Pharmacologically, otherwise, whether you're using over-the-counters or prescriptions, it's important to know that most of those medications, if not all of them, don't really actually help you sleep well. What they do is make you amnestic for waking up. You don't remember waking up as much during sleep. They're actually not helping you get into the stages of sleep that'll help you feel restored. Now, don't get me wrong, not remembering waking up can be less stressful, but the fact of the matter is it's not quite what the other types of things you could do here, like cognitive behavioral therapy or yoga nidra provide, which is relaxation, getting into the different stages of sleep and feeling restored after sleep. So again, something important to talk with your oncologist about. There are sleep doctors. They're often not quite necessary, if you will, from the majority of our patients. What can be very helpful if you need is cognitive behavioral therapy, and for that type of insomnia-like problem. And again, if you Google that or put it in AI, you can find a great deal of resources. There are a variety of people here at UCSF who also provide that type of care in the psychology department. The next is stress management in terms of lifestyle modification, right? So sounds easy, but is amongst the most difficult things to do, right? And getting your cortisol level down and helping your body work appropriately is going to help your immune system not only fight tumor, but also help recover after any chemotherapies or treatments we're putting you on. And so how to best do that? Well, different strokes for different folks here as well, right? Different coping strategies such as relaxation practices and the like are going to be very helpful at decreasing depression and anxiety related to both the diagnosis and its treatments. Of all those available therapies, both mindfulness-based interventions and yoga do seem to have robust evidence for stress management, and beyond that, cognitive behavioral therapy. So those three things have direct scientific proof that they help, right? They can be a bit of a black box for patients. Finding a good cognitive behavioral therapist in your insurance plan is not the easiest thing to do, but you start on that insurance plan's website, you see who's in your plan, and if not, who might be in your area, who might be able to take your insurance and or get you retro billing if you pay out of pocket. Yoga and mindfulness, we'll talk a little bit more about as you go, but yoga, technically speaking, is a meditation breath-based practice, right? If you're doing it quote unquote correctly. There are obviously all kinds of yoga these days built for more vigorous exercise, but being in your body through that strategy is important. I think, again, definitely leads to reduced stress and improved physical dynamics, and can lead to improved both health span and lifespan. And all along, this leads to socialization, which is, of course, robustly important. If we're human beings, we're relationship seeking, and forming relationships with a therapist and or with other people through mindfulness-based communities and or yoga-based communities, I think is of paramount importance. So the next is that expanding on the mind-body intervention, if you will. So the NCCN, as well as others, do recommend that acupuncture can be a good way and scientific proven way of addressing any kind of pain, fatigue, nausea, vomiting, hot flashes, what have you, in the setting of what you might be going through in terms of how you're being individually treated during radiation or chemo or what have you. And then actually more than 80% of the NCI designated cancer centers do recommend acupuncture for those types of symptom management. And it's always amazing to me how patients don't know this, but it can be and is often very helpful for, you name it, headaches, muscle tightness associated with your incision, nausea, what have you. And it's all about finding the right practitioner. And again, this does take some doing. There are practitioners at UCSF, but you want to look for people who've been to an acupuncture school that's a couple of years long, not a couple of weeks, and that they're generally practiced in traditional, if you will, Eastern or Chinese medicine and have learned all the techniques that are related to those specific disorders, if you will, that they're managing, whether again, nausea, headache, what have you. Um, you know, when patients put me to the sword and ask me how it works, I'm not sure that I agree with, if you will, the traditional Eastern explanation. I think in some ways, and in many ways, it's forced meditation, right? You're forced to lie still, relax, chill. You become conscious of the part of your body the needles are in and often relax the fascia around it. And it probably does lead to, blood cascades of sort of anti-inflammatory like chemicals that can help both fight disease as well as make you relax. But again, much, much more to be discovered and studied within that realm. Mind-body intervention and the next is massage, right? Oncology massage, general massage. This is also studied and does help with cancer-related fatigue, pain, mood disturbance, and what have you. Can be very helpful for spine patients, spinal tumor patients and spine patients in general, but it's much shorter in its benefit, if you will, and somewhat unsurprisingly so. But when you compare it head to head against acupuncture, acupuncture actually wins out in terms of long-term benefit, which is interesting, right? Because I think maybe acupuncture employs more of your own mind as you're thinking about it. I don't know, but massage also has its role in helping with patients, and of course does lead to relaxation and decreased stress as well. The next mind-body intervention we discuss is meditation, one of my favorite things to advocate for patients to engage in. And for patients who are out there who know me, I practiced Zen for a long time, so I'm biased in that direction. But it is actually studied as a secular form of breath-based meditation or mindfulness, does reduce stress, does improve in mood and being, physical measures of improvement in the quality of life as well, right? And so fatigue, depression, anxiety, fear of recurrence can all improve here just by paying attention to your breath. And the magic time of that, or it seems to be about 2 12-minute periods a day. So if you have that in your, ballywick, then I think it's an important thing to do and also can lead in terms of improvement of sleep and relationships with your spouse and family members. How you do it, I don't mind, right? And the evidence would say that breath-based meditation is better than anything else that you can do, whether it's focusing on different parts of your body or body scans or transcendental meditation. Breath-based meditation does come out on top, and that's simply learning to, in the position you're comfortable, lying down, sitting in a chair, what have you, paying attention to your breath, either through your nostrils, through your mouth, or paying attention down deep into your belly and as your belly moves in and out during breathing. And what that's doing, in my opinion, to explain it in a kind of Sesame Street simple kind of way, is, we all have about 40 some thoughts per minute, whether you're aware of them or not. What you're doing is taking enough time to notice the thoughts that one domino of thought doesn't crash into the other. You get a little bit more knowledge of who you are, how you're thinking, and so that your thoughts aren't you, you're your thoughts, right? In a sort of weird way. But I think that leads to an improvement in attention skills. It leads to an improvement in coping skills. And in essence, gives you the time to be not so reactive, and instead you get to live your life by vow rather than habit, so to speak, right? Makes you less of a creature of habit, makes you more of a creature of who you want to be, right? Life is not, you know, what you choose, life is what you live, right? So I think it gives you that superpower, if you will. To that end, right? and a little bit more about meditation here. I do recommend the apps that are in the corner of the slide, Balance and Waking Up. Balance is nicely structured app and proven one of the more scientific studied apps of taking meditation and putting it in different 10, 20-minute installments, making it easy for people to engage in. Waking Up by Sam Harris. I'm a big fan of Sam Harris by disclosure, but a much more sophisticated trip through any kind of meditation that you can think of. And again, Kelly Boyes is on Sam Harris's app. She has her own YouTube channel. She's great for yoga nidra and body-based meditations and breath-based meditations as well, which can help with fatigue and sleep and cognitive function and get you out of that chemo brain to a degree. But also can help with mood, as I mentioned. So I would refer you there for more information. Sam Harris, for what it's worth. Again, I don't have a personal relationship with him, but he's here in San Jose in a few weeks giving a talk. And so I'd also refer you there for more information if you're interested. And if you're in the Bay Area or the like, you can get, I'm sure if you Google meditation, breath-based meditation, many places will come up here in San Francisco. Like I said, we have the Zen Center, which is a luxury, and in North Marin, we have Spirit Rock and the places like that, which you can get a one-day online or in-person course to help you get started. Beyond that, I mentioned yoga, but Tai Chi, there are several large meta-analyses and systemic reviews that prove that yoga and Tai Chi can be beneficial to, again, both getting in your body, being less fatigued, getting more energy, but also potentially leading to better sleep, better mood, and even perhaps better health span and lifespan. Again, these are not the easiest things to engage in if you don't have any experience in them. But if you Google or search, UCSF does offer, I think neuro-oncology through our caregiver groups do offer exercise classes that cover both from time to time that can be significantly restorative to you. So everybody wants to talk about natural products and treatments, of course, as well as part of the integrative experience. And again, whether you should use any particular product my answer is always it depends on your total care, right? You shouldn't leave this talk saying, Dr. Butowski said to use creatine. It depends. It depends on who you are, what you're on, what your goals are, and should be discussed with your physician. But if you want more information, like I said, the Society of Integrative Oncology has their annual meeting in Boston in October, and I believe they do make it online, both during and after for patients. And what I'm putting in here as natural products and treatments is defined. I'm not going to read it to you, but any dietary supplement that you can think of that people might want to be interested in, we're going to cover some. And again, these are things you should ask your physician about because, for instance, I like lately with a lot of patients on vorasidenib, which can elevate your liver enzymes. I find that there's this small but definitive pool of patients who are having a greater bump than I'd expect. And what I found by greater questioning, even with my patients, and I thought I did a good job at asking, like, what else are you taking? And it turns out people take stuff that I'm like, oh, that might be the culprit. You go off of it, the Vora then doesn't bother your liver as much. So we're going to talk about a couple of different things. First is protein supplementation. There are trials out there that show that protein supplementation combined with rehab does improve outcomes, particularly in patients who are struggling, right? So I do think that protein supplementation is good. The thing to know is, of course, it's probably easiest and best to get it from lean sources of protein. So, if you don't know, the best kind of sources of that are poultry, right? Organic poultry being better. Venison is very lean. And then you go from there, right? Different cuts of different types of meat are going to be leaner than not. And you can ask an AI or, again, Google it. But I tell patients, hey, look, I'd stick with fish, wild caught fish like salmon or venison from a company like Maui Nui, which isn't cheap, but is good, lean, and particularly protein rich. Other supplements in terms of antioxidants and what have you, we've seen everything studied, but just not studied really well, right? There's a crucial lack of good studies for long enough to make a specific recommendation about any specific product, right? And we'll go over some in particular in the future slides, but whether herbs, vitamins, minerals, probiotics, one, first and foremost, get it from a company that you consider reputable. I like Thorne because most of their products are tested for pro athletes, so you know they've gone through third-party testing. There are other companies out there, and again, I have no relationship with them, but to me, I always say to patients when they ask me, well, what company do you use? I use Thorne myself, but and that's Thorne, but there are others that are probably equally good and perhaps less expensive that you get vitamins and protein supplementation. On the protein supplementation, I think that whey protein is the most easily digested and probably safest, if you will, but you can use other sources. When you use pea protein or non-animal sources, just be careful about what else it comes in because that's going to affect your absorption. And if it's promising 10 grams of protein, you may not be absorbing that. So you have to be careful. I don't want to make statements about exactly what the absorption is because it is going to differ per product, but you don't get 100% absorption for most non-animal-based protein supplements. So other natural products that patients often use, and you can look at this slide and see and go across these websites for more information. But a lot of patients do use antioxidants, our sort of bug our radiation oncology colleagues, because maybe those antioxidants have uh, a way of counteracting radiation, although I think that data is pretty poor. But high dose vitamin C, amla powder, which comes from gooseberries, have high antioxidants. Patients are often on them, and they can be, the literature would support, at least preclinically as well, that they can be helpful for tissue recovery. That's been, so if you're suffering from radiation injuries, maybe after radiation, they're good. But whether or not they cause tumor growth, I doubt, but you never know, right? Sometimes, again, for a particular patient, you need to talk to your patients. Be careful about Chinese herbs and the like. They often have anticoagulant properties to them. So if you were thinking about a reoperation or have low platelets, those are things to be aware of. Other types of herbs can interfere with hormones in your body, right? Whether on estrogen or testosterone. So again, those things can be and should be discussed with your physician. Immunostimulant herbs are very much in vogue, if you will, things that are supposed to boost your immune system in a way to fight tumor, whether mushrooms or what have you. Again, best discussed with your physician because sometimes they may actually be immunosuppressive. And depending on what other treatments you're on, you want to be careful about what that balance ends up. And again, the major issue here is quality control. I guarantee you there aren't great studies of any of these compounds. And if there are studies out there, they're often for like 4 weeks, which doesn't tell you much of anything, to be honest with you. And so both the Society of Integrative Oncology and American Society of Clinical Oncology determined that there's little to no evidence for using supplements in brain tumor care or other cancers. Of course, that leaves most patients unfulfilled, and most patients do end up using, and we'll go through some specific products in a bit. Right now, in fact. So patients ask. So you can take a look at this slide. The slide and what I say might be different to a degree because again, it depends on the particular individual situation. Creatine, which is most people are familiar with, is what bodybuilders use to build muscle, right? Some preclinical studies actually show that that might fuel metabolism in GBM, and other studies show that it doesn't, right? So there's no evidence one way or the other, and there are risks and potential benefits. More recent data actually would say that 5 grams of creatine a day actually really does help with overall caffeine like energy like effect. Your liver and your brain make a certain set amount of creatine a day, and recent studies both show that creatine is helpful for brain injury patients and helpful for both sleep and energy. Now, these were general populations, not just brain tumor populations. So again, you have to contextualize it as what are your goals and whether you want to use it. A lot of my patients do use it and supplement with that. And a lot of people have said that it does give them that energy to get through the end of the day. But again, it depends on how often you use, what you want to use, and so on. And giving individual advice here is very difficult. But I will say that when you go on it, if you go on it, 5 grams per day, you need about 3 or 4 weeks before it actually gets to your brain. That because your muscle and your bone have to be saturated first. So there are recommended higher doses out there that you can do. And I point you to either Peter Attia or Rhonda Patrick's more 2025 podcast on this subject for more information. They go 2 hours in depth on the topic of creatine supplementation in a general sense, but it is something that you can put into your own care. Multivitamins, right? They're great sources of antioxidants and reduce cell damage, but there's no evidence that it prevents cancer and no real downside to using them, probably. They may interfere with radiation. I doubt it. They don't interfere with most of the chemotherapies we use. And high dose supplements like high dose vitamin C, say over 1,000 milligrams a day, can help with brain injury and free radical scavenging. What else to use in that setting, again, should be discussed with your physician in general. A lot of patients do vitamin D, vitamin E supplementation. Those are things you can overdose on and should be followed by a dietitian. And I send patients now for a dietitian assessment, and they do this whole panel with blood. It's just, insurance pays for it, and you can get really specific advice for you. I put deer antler on here because it's been asked about a lot lately. I think it's been on several podcasts. It reduces proliferation and promotes apoptosis in GBM cell lines and in mouse models, which has been interesting and I think recently studied. There's no evidence in human clinical trials yet. It may have some hormone-like properties, so you have to, be careful of that. The official recommendation is to avoid because it's got unproven efficacy and potentially some safety concerns based on those estrogen-like properties. But a lot of patients have used it lately. I haven't seen any negative uh, signs in my own patient population, of course. Where to get it is, of course, of significant debate. A company, again, like Maui Nui, which is Maui as in Hawaii, Maui Nui, N-U-I, is where I'd point you to. But again, whether it helps or not, I don't know. Curcumin and curry powder and turmeric definitely out there in preclinical studies. This drug in sufficient, this molecule in sufficient quantity can kill and inhibit brain tumors. But what that dose equates to in a human being and with a brain tumor, nobody knows, right? There's inadequate evidence to recommend it. The problem with curcumin in general, it's got poor bioavailability. It doesn't get into your system very well, and it does interfere with blood thinners if you're on them. And like I mentioned with Vora, it can cause some liver issues, right? So most recommendations or most guidelines say avoid it. I think the Thorne product has much better absorption if you do want to use it, and again, has to be contextualized in the remainder of your care and other medical problems. Quercetin or quercetin. Some people say quercetin. I really don't know. I've asked AI a bunch of times how it's appropriately pronounced, and they give me all three answers. So this is a molecule found in like berries and onions. It inhibits cell proliferation and angiogenesis in tumors. There's no real evidence in human trials for brain tumors or other cancers. It does have a lot of drug interaction and does interfere with liver enzymes. Again, you got to be careful about what else you're on. So its broad spectrum effects makes it high risk, depending again on what other drug treatment you might be traditionally on. But a lot of patients do take this as well as an anti-tumor property because it's not going to really have an effect on Temodar, so to speak, right? So it's safe to take. Omega-3s, pretty high doses do induce damage in tumor cells. So there again, in the human being, really no evidence. It also can increase your risk of bleeding and should be avoided with blood thinners. So again, consult your oncologist. The potential for drug-drug interactions are present itself, and I'd rather you get this through eating fish than taking supplementation, but it may not be the worst idea either. We're going to talk about cannabis in a more extended way. Everybody asks about this, and somehow in some corners of the world, I've become an expert on this. I have the appropriate DA license to study it and have tried to put it in mice and study it in human beings. And those studies are ongoing, so I have no real official conclusions yet. But to get us all on the same page, right? Cannabis is made of about 407 different kinds of chemicals, but most people talk about it in terms of CBD and THC, right? THC gets you stoned. CBD has more of an anxiolytic effect on it. Hemp is what has high CBD but low THC and is legal, right? So most state, or I don't actually know about most states. In California, obviously it's legal, but in some states it's not. So you always have to have the disclaimer about that, right? At a federal level, it remains illegal. At a state level, it varies. And so it's technically not a prescription. And obviously, or what I hope is obvious, where you can get this is dominated by recreational use, right? So I send patients often to the collective in Marin, run by Leonard, called Synergy CBD. Again, I have no formal relationship with him, but I find his website, either that or Healing Essence CBD, they're connected to be good educational resources for patients looking for more information on what products they may want to use. Because it's kind of like wine in a way, right? Different strains of cannabis have different like outcomes, right? Some make you sleepy, some make you awake, some, make you less anxious, some may make you more anxious, depending on both the strain and, of course, the combination of CBD and THC in each product. So the National Academy of Science said more research is necessary. They're not going to come out with any kind of um, official recommendation anytime soon. So just to make sure you're aware, and this is kind of a history of what's gone on, right? If you look back, actually, marijuana and the hemp industry had a lot of conflict early on with the paper industry, and that may have led to some of the laws that we have now. Later in the 1980s, you have a prescription-based product that is helpful for nausea. And of course, in general, cannabis is helpful for nausea, again, depending on how you take it. There's been a couple of approvals for those types of things for nausea and chemotherapy-induced vomiting. And cannabidiol actually in 2018 was approved for seizure. And cannabis is a decent seizure medicine when used as a medicine, right? Used regularly, on time, same amount, same product. Can't actually be a seizure medicine. So again, something you can discuss with your medical care as an add-on and or, when and if you have a seizure, like did you stop your cannabis? Those types of things can be extremely important. There's all sorts of forms of cannabis. We've had many patients over the years bring us in special brownies, which I always have to ask, like, how special? But whether you're taking an edible or a tincture, I personally, I like, a controlled environment tinctures where you know what the percentage of what you're getting CBD wise, what you're getting THC wise, it's reliable, the absorption's easier. You inhale or vape, which I wouldn't recommend doing for obvious health other concerns. The effect of whatever you're going to feel is relatively immediate. If you take a tincture, it's going to be 20 or 30 minutes before you feel anything at all. Edibles and what have you are going to be longer than that. So you have to be careful about, whether it's going to get you stoned or not. And there are these prescription-based uh, pharmaceuticals you can use as well. We typically don't because insurance won't necessarily cover them, but they're always open for discussion and they're indicated again, mostly for nausea, somewhat for seizures as well, control. But I've had a number of patients over the years ask for prescription-based cannabis products rather than going to the dispensary, but most patients end up going to the dispensary and getting what works for them, if you will. There is logic here, right? The cannabinoid receptors are obviously expressed in brain. They're expressed in your peripheral nervous system too. They do have an immunomodulatory effect and likely effect on growth. What I'd love to do is a clinical trial where you take patients with particular kind of brain tumor, test if the cannabinoid receptors are expressed on that tumor, and whether then giving them a said product inhibits growth, which is what we think it does, right? We think it slows down growth in a way it kind of slows down your brain, if you will, making it very Sesame Street simple there. But that's the recognized, if you will, mechanism of action. There's been a number of studies in terms of how these types of products can be useful. They can be decent sleep medications. They go beyond just making you amnestic for waking up. And again, finding the right type of product for you should be discussed with your physician. They're very good pain medicines, very good nausea medicines, very good seizure medicines, very good appetite stimulant medicines, again, when used with the right product and dose. Here gives you a review of what has been done in the seizure world. And again, there's ongoing trials within this region, both at Columbia and other places here included, about how these products can be used. We have a high CBD product that was used at 500 milligrams, and hopefully in the next iteration, should I get funding in the next month, will be used at 750 milligrams. So it gives you an idea of where CBD might be used, right? So we think a minimum of 100 milligrams might be anti-tumor, but it may way up to even 750, 800, you get into potential psychosis. So you have to be careful. THC, most patients can't tolerate more than 2.5 to 10 milligrams a day, sometimes a little higher. So within that realm, again, something you should discuss with your physician, or even the people who work in the dispensary can give you guidance about, hey, what do other people who come in asking for anti-cancer drugs, what product do you give them? What do they like? What do they come back as, for return customers? I think those people are knowledgeable as well. And I wish we had more funding to do better studies, but I'm trying. We've had studies approved and funded by the CMCR. We're looking for the Department of Cannabis Control in California to fund a study soon. So, keep your fingers crossed that those happen and we can answer these questions in a more definable way. This is the stepwise approach I use to broach this subject with patients. It's again something that, what's the significant effect on you psychologically and just physically? You don't want to fall because you're stoned, of course. You want to know what hepatic and or kidney dysfunction might come from it, and what else, what other medications you're on, and what other drug interactions may happen. But this gives you an idea of the conversation maybe you have with your physician and how it should be guided about whether or not to use those products. Again, coming a little bit full circle in summary of what we've talked about thus far, how to look at integrative oncology consultation with your oncologist or dietitian or integrated medicine physician. It's lifestyle management. What nutrition, what diet things you can do, what physical activity modifications, what sleep hygiene, what stress management, right? Urban supplement consultation with a dietitian or oncologist is important too. Assessing what are my goals, what other therapies am I on, what other health problems I have, how am I, looking to address those, and then symptom control, right? What symptom do I have, and how might these lifestyle or supplementations be helpful for pain, fatigue, insomnia, anxiety, and what have you. And what beyond that might be relevant, right? So that's a minor summary before we also talk about things that also generally dovetail into integrative care, and those being palliative care to hospice, right? So palliative care, you're looking for palliation of some symptom. Hospice, you're looking for end of life care, right? So it's a continuum often in our world, too often. But how do they dovetail, and how can they be considered with your goals with regard to that? Pain management, we've touched on. What things help with pain? Acupuncture. What supplements may help with pain, right? Cannabis lotion, right? Can be very effective for pain and tightness, for incision and scar. And how does that blend into what and how an individual patient defines health span and lifespan? Health span meaning how healthy are you over time? Lifespan, how long are you going to live? And what does that mean for survivorship for both patient and caregiver, right? All of these should be discussed globally and are very important and shouldn't be forgotten. Beyond that, there are some tech ads that I throw into integrated medicine, right? So the tumor treating fields, there are mainstream treatment, of course, but there are to be thought of, or often thought of as by patients as like, how do I integrate this right into my daily life? It requires a more complex discussion than I can present in 2 minutes, but it does take motivation, right? And that motivation has to come from somewhere and is often very much connected to things we've touched on in terms of being physically fit. Wearing Optune 18 hours a day, shaving your head takes a motivated caregiver and a motivated patient. There are other things like transcranial magnetic stimulation and what have you that are both used for preoperative kinds of mapping and may be used in some corners of the world in integrated practices, trying to stop the tumor from interacting with normal brain and therefore perhaps stopping it growing. Those things are in their infancy, if you will, as are ultrasound-based therapies that reduce the blood-brain barrier's ability to block certain medications. We both have those in clinical trials here at UCSF, but they're not yet connected to integrated therapies, but I'd like to get them, right? Get them there eventually, but we need a more mainstream product to use. Magnetotherapy, also is something that patients often ask about. This is not ready, if you will, for prime time treatment. Needs to be studied in trials, and that's where you use some kind of localized heat to kill cancer cells. Yes, you do have lit therapy, but beyond things that are non-invasive that can be done in an outpatient setting, we're not quite there yet. But I always mention them because patients often ask about them at the end. And then patients want to ask me about off-label use. And again, this is more, if you will, mainstream oncology as much as it is integrative. But these are amongst the most major things asked about, and often in a talk like this, patients will bring them up anyway. So in the next 1 or 2 slides, or perhaps even more, I bring up the medications most often discussed: gabapentin, Neurontin. You're going to see, I'm not going to read the slide to you, but it's strongly recommended and will move forward in clinical trials, and patients can add 450 milligrams, say, once a day or more to their care and may have a role. I don't know whether it does. My clinical experience is all over the place with it. It's an easily tolerated medicine for the most part, but whether it's truly been a common thread in my long-term survivors, I haven't recognized. That doesn't mean it can't be, but I am curious to see. Metformin gets to how you're regulating your blood glucose. I'd much rather you regulate your blood glucose through diet than using a medication that affects your liver, but it does have some promising data, both in small little trials in brain tumor patients, but across cancer patients. But it awaits more robust clinical data. And what the dose of metformin is unclear to me because, of course, it may be, again, if you're going after that glucose effect, different dosages might be needed in different patients depending on, your weight and what your diet is, right? So I think it's going to be a muddy kind of recommendation in the end. Everybody asks about mebendazole. It binds to tubulin and prevents microtubule polymerization, so it does lead to cell death pretty compellingly in preclinical models. The problem is getting a clinical trial dose that's effective in patients is really difficult. And does lead to other bone marrow blood count problems. There's potential there. I don't personally think that there's a there for the dose that we would need to use in patients. And it does really interfere with other medications we use, so can't be used in combination. And as a sole agent, in my opinion, is likely not effective. I put ivermectin on this because, Joe Rogan mentioned it in his podcast, and so every patient asks for it. It's out there on the internet. In short, it should not be used. There's no real clinical rationale to use it in brain tumor patients. It does lead to significant toxicity at high doses, probably ineffective and very toxic when used in combination with many of the other things we'd use in the brain tumor population. So no role for it, in my opinion. Prozac, out there from some unique studies done by Paul Michel and others. We're awaiting clinical proof. And again, this is like gabapentin. What dose needs to be in patients? How do you translate preclinical, whether in the dish or in animal models, to the patient? And you'd be surprised at how often that's the kind of least studied thing in a lot of experimental drugs. You find that it works in vitro in the dish and in the animal models. Animal models are all over the place with what kind of model you use. But how does that really translate into a human dose that makes sense for getting into the brain in sufficient quantity to provide a lethal effect to tumor? So there's some promise there. There's a low downside like gabapentin often, but again, how many pills do you want to be on? How many medications? How do they interact? Needs to be thought of. Patients still often ask about proteasome inhibitors. There is a there as well, but again, translating dose has been very difficult here. In essence, they can be used for cancer in a variety of situations. However, they don't cross the blood-brain barrier well. And so maybe I feel like the studies that looked at marizumab in brain tumors were too early. They should have been combined with some of the ultrasound techniques that we have, and might be more attractive than the agents that we're currently using in some ways that are old school. But I would keep an eye on this as companies develop other proteasome inhibitors, later generation proteasome inhibitors, because there could be a there, but at the moment, I don't recommend off-label use because they have the high potential for toxicity and are the ones that are just commercially available, don't get into the brain. I think this is my last slide with such medicines. I'm again brief review of many of the medications, statins, doxycycline, DCA, minocycline, often asked about. Statins warrant further research, right? Lipid profiling, there are better drugs out there that probably inhibit what statins do. But whether or not you can take it safely as well in combination with other things is yet to be proven. I don't think doxycycline at present has enough proof to warrant looking at it. DCA does have robust preclinical data, but clinical data is completely missing, and I haven't come across clinical proof that it has much of a there, so to speak. Minocycline, again, promising preclinical data, not been used extensive in trials. And long story short, because I think that's been a bit of a common theme throughout many of the supplements and off-label uses you can talk about. The problem with translating something from dish to animal model to human is robust, and is part of my job on a daily basis. It's real easy to take any molecule and make it look good in the preclinical realm because there's always some model that is woefully deficient in the heterogeneity that GBM can manifest in a human, right? What you'll study in a preclinical model often is addicted to, say, like one highway of growth, and you can block that highway and say, hey, look, great, it didn't grow. But GBM in a human being is a completely different beast. They're often shapeshifters, right? How you treat them then gets at how it changes, or perhaps more importantly, you can win the battle by fighting in a certain way, but that doesn't mean you win the war. What I mean is that tumors may be a response to abnormal or an abnormal response to wear and tear, right? That's always something to be considerate of. With radiation, with Temodar, with supplements, with whatever, you can maybe win the battle you know about, but your abnormal response, how your brain has been destined, if you will, to respond to the aging wear and tear, may cause another tumor, another stem cell turns on, migrates out to the place that you had your original tumor, making it look like it's a local recurrence, so to speak. And that's what you have to be concerned about in terms of battling this disease is what is the underlying mechanism? Why do patients get this? And I wish I had better answers and I wish I had better therapies, but these are some things that fundamentally need to be addressed and the causal nature of them before we understand how many of the therapies I've discussed tonight can be better applied to the right situation. And I think that's what the common thread is amongst my long-term survivors is they got the medicines that they needed over time, somewhat luckily over time, and they were open to listening to me and our team here about what makes sense for the time point they're in. Some of my more famous long-term survivors that are out there spent large periods of time doing nothing, right? They took care of themselves, but they weren't on active treatment, if you will. And sometimes that's the right thing to do, right? So just to give you a bit of hope and perspective. So in summary, we have a growing number of cancer patients in general, and in particular, obviously for brain tumor patients in our clinic that want to engage in these complementary, alternative, and integrated medicine types of practices. But patients are often reluctant to discuss or their oncologists are not necessarily knowledgeable and can be maybe even dismissive about them. But if we get into a more integrated oncology approach, there's someone out there like me, someone out there who specializes in integrative medicine or dietitian or the like, that you can discuss with this because there is evidence that mind-body practices like meditation, lifestyle modifications like exercise and sleep, and even natural products can provide both health span and lifespan benefit when used in the correct situation. And we have to prioritize safety and we have to prioritize that evidence first and foremost to make sure our patients do well. There are a few opportunities for oncologists to learn about integrative oncology. And I tell patients, hey, man, you got to be your own best advocate. Educate your physician too, right? So as patients are out there, go back to your physician, go back to your team and say, hey, look, there are ways you can find out about this through SIO, through ASCO. I encourage you to do it. Keep your doctor on your toes. They'll appreciate it in the end, right? And empower empower your team to empower you. And with that, yeah, I take questions. Happy to do so.
Thank you so much. That was so comprehensive. I think that's one of the most comprehensive presentations I've seen on this topic. Um, I guess let me start with all the questions. The first one I would ask is, you're talking about on the practitioner side how they can learn more about this, but on the patient side, how do they go about finding, outside of San
Sure.
Francisco, how do they find a good integrative oncologist, and specifically with neuro-oncology, that's a kind of a special niche.
Yeah, I mean the main way would if you're connected in any way, shape, or form to an NCI designated cancer center, they likely have an integrated medicine division, if you will. So you could Google UCSF and find it. And like you said, like I said in my talk, you have the Osher, and you can meet with people like Don Abrams who are great, um, and get some advice. You don't necessarily need that though. You can find a dietitian or a nutritionist close to you that can give you that part of the advice. But in reality, often patients in the community need to separate out getting advice on these different topics from different people. I'd start certainly by talking to your neuro-oncologist and saying, hey, where have you had experience to educate patients on these topics? I will say that most of the time the education is still patient motivation driven. You have to be sort of self-education. These days, luckily, you have things like Gemini or ChatGPT where you can ask, um, and have in Gemini, you can do the Canvas-based learning. And I'm not as proficient in ChatGPT, but there are wonderful resources. And I do it myself, and patients come in and educate me. So I point you in that direction. I think. There are some topics hosted on the SNO website that cover this as well. So Society of Neuro-Oncology website, that I'm aware of, that might give you more information as well. And then last but not least, I think just talking to other patients, right? And support groups like this and the like are going to say, hey, where have you found the best resources about things? I do think that book by Mike Greger, How Not to Die, is a wonderful resource for nutrition and diet.
Okay. Yeah, and one of the, I guess the feedback I hear most often from patients is that they're getting contradictory messaging from these different sources, and it's really hard to,
Yeah, yeah.
I guess, put
It
it
all,
all together and
yeah,
make the
it
choice. Yeah.
all has to be contextualized. And I think the way that information is presented, um, is often in a biased way, right? And so yeah, as a patient, you understanding that bias is challenging, and your practitioner maybe paying attention to that level can be challenging as well. So yes, you are going to find, just like in mainstream diet recommendations, you're going to find contradictory evidence. I think ultimately, when we have enough big data in one place, which we don't, you're going to find that eating in season, eating a 90%, plant-based whole food diet, um, and then adding in lean animal protein is going to be the way to go, and is going to be connected to all sorts of disease. Meaning, when we were kids, when I was a kid, I cringe now and I'm like, oh my God, I can't believe I used to eat that snack when I came home. But I think that, and we didn't eat in season in my house, but we do now. I think those are critically important for things like immune mimicry and what have you. They're just not well studied.
Okay. And for those that are specifically interested in keto, can you speak just a little bit on what the diet is you're using for that GBM newly diagnosed trial? And is there anything you've learned so far in
Sure.
running the trial?
Yeah, so keto, you're basically looking to get your body in ketosis so that the body burns fat for energy instead of carbohydrates. And that is thought to be rate limiting building block wise to the tumor. Again, getting back to that, it might just be that your blood glucose level needs to be on the low side, so to speak, of normal. But it's a high fat, low carb diet that helps to put your body in keto. And it's a fuel utilization issue, right? And so we have a dietitian. That no patient would be able to do this without a dietitian. A dietitian is part of the study. The study randomizes you either to getting dietitian help to be on keto or just dietitian advice to do general diet. Um, A lot of patients struggle with keto, though. It's really hard to stick to that. You end up, we joke, we call it the avocado diet, because a lot of patients end up putting avocado as a source of high fat into there, right? And it's eggs and cheese and nuts, and your family's not eating the same stuff at home. We really haven't found any significant results yet. It's early. It's a multi-site study. Jethro Hugh, who's the overall PI from Cedars, will be presenting some data in September. So ask me again then, because I don't have aggregate data for all sites. I'd say universally it's tough on people.
Okay.
Uh, I have had, if you put, you know and make me answer, like, what do you think the most important? I suspect it's the blood glucose. But whether you get there through keto or other means is up to you, like intermittent fasting or what have you. Um, and the common thread amongst my long-term survivors is good diet control, and probably cannabis use, which might be just selection bias for where I work. But those two things I think are critically important.
Okay. Next question. You went through a lot of repurposed meds individually. Do you think that there's any merit to, for example, the Cure Oncology protocol or the CUSP-9 protocol where you put together several of those?
I don't know if there's merit per se. I think the problem is that they have to be contextualized to the individual, both based on what other treatments you might be on, what other health problems you may have, how those medications may interfere, how those medications may interact with each other. And then probably, what I didn't touch on in the talk too much was the molecular biology of your specific tumor, right? So no two GBMs are created equal. You want to know what the genetic findings, the sequencing results of your tumor are, and then how they relate to the choice of those medications. Are the choices of medications mechanism of action wise, an informed logical choice for what your tumor has mutated, altered, or what have you? Um, so yeah, I can't give you a better answer than that. I think again, most of my long-term survivors have sort of done the vanilla pathway, and with maybe some of the additions of things I spoke about in terms of vitamins and supplements, but not so much the repurposed commercial prescription medications. I have not found that to be useful. Now, whether gabapentin or Prozac at specific doses provide benefit, I think those are curious.
Okay. And thoughts on supplements for cerebral edema, specifically Boswellia?
Good question. Won't hurt typically. It is something that I think can interact with some other things you're on if you're taking it in sufficient quantities. Um, it in and of itself is not going to make the edema go away. Might provide an extra benefit, might like reduce your decadron overall need or something like that. Um, yeah, but I get asked about that a lot. I tell patients to go get the Thorn product if they're in a place and state where I think adding that into their care is safe. Like sometimes patients get on steroids and have a real hard time coming off them, and maybe Boswellia is a little bit of a crutch to help with that. Solovum too, which is another molecule found in like a Swedish cereal. Sometimes patients use that. I failed to mention in my talk that they use that in GI diseases where the
Mm,
gut gets swollen and then they give them Slovim and it reduces cell size and edema. I don't think it hurts. Whether it really truly helps or not is again something to be individualized in context for the specific person. But yeah,
mhm.
yeah, it's certainly something that you can.
And that Salavum is in a phase 2 for GBM right
Yep,
now.
in Sweden. Yep.
Okay. Someone also asked about Ruta 6, which I'm assuming Ruta graveolens and Calcarea carbonica. Are you
Yeah,
familiar with those?
yeah. I'm a little.
Oh, is that Banerjee that did a study years ago that was never replicated with those two?
Route 6 has been around for a long time, and it's supposed to, if I remember correctly, help both promote lymphocyte survival and engage in tumor cell death. I personally have not seen it help. Whether it truly interferes with something, I'd have to go back and look up. I do remember that it might interfere a little bit with liver, and there simply is no rigorous large-scale clinical trial. And trust you me, I know I'm a Western doc, but if any pharmaceutical company or even someone like me thought, hey, look, man, there's a there and I can make some money on it, they would go forward, right? There's no like conspiracy theory to keep things off the market. There is when patients say, "Hey, look, if what do I want to use?" Like again, I point you in the direction of like things that we know that get in the brain, things that have decent preclinical proof that's repeated in more than one country and so on. Like cannabis even is probably a better choice. So when patients say, "What can I use?" I'm like, "Look, my top three choices would be like think about gabapentin, Prozac, cannabis." And we'll talk about supplements as well and where a particular individual is at.
Okay. And hyperbaric oxygen therapy.
Yeah, so hyperbaric oxygen therapy, brain's in a pressurized environment, so you're not really going to be able to likely change too much the oxygen content. And so you're not going to get you're not going to overcome the hypoxic or low oxygen environment that benefits tumor in that way. So I think that's been largely proven in my opinion. Um, Now for recovery from brain injury from radiation, there could be a there. It's really hard to do and study. Ed Aronson did many things in Colorado over the years. The problem is that it can cause seizure, and so the studies are difficult. And of course, radiation injury from patient to patient is uniquely different, and so hard to study something that's so that is not uniform, that's so heterogeneous in its manifestation in terms of time and um, timing in relationship to radiation, how extensive it is, and whether patients are doing other things, right? So the problems with those studies is patients are often trying numerous other things to help with the radiation injury. I think there are probably more direct ways to help people.
Okay. Red light therapy.
Ooh, good question. I don't think it sufficiently penetrates um, your skin to get into brain to do anything, is my recollection. Uh, there's burgeoning evidence that very superficially can help with muscle tension. So like photomodulation, um, deeper than that, I don't think they've mastered that without popping your skull off, so to speak, and doing it directly. And that is of interest. And there have been some companies in that space. Very difficult, very challenging, very expensive to do that kind of direct light cell death therapy. We tried to do a study and the company went broke before we could get it up and running because there's so many safety assessments connected and you have to admit patients to the hospital. Um, Something to keep our eye on in the future, but at present, I don't think buying a $400 machine for home use is probably worth your while.
Okay, all right. Next question is pretty specific. I'm supporting a close relative with GBM. His CBCU labs have been poor lately. Low white blood cell count, low platelets, low lymphocytes. I know there are cytokines that are being explored to boost lymphocyte levels. Is this something that you have advice on or something we should ask a neuro-oncologist about?
Well, certainly you should ask your treating physician about it because it's going to be peculiar to the cause of the myelosuppression or low counts.
Mm-hmm.
Um, and that relationship is going to be important in how you manage a patient. Uh, there's a little bit of um, data out there like that mango and what have you can be helpful with reestablishing counts to a degree. I don't want anybody to go out there and eat a mango every day, though. So the supplements that you could use to help, probably you get them all in a multivitamin, to be honest with you. Things like folic acid, iron, vitamin D, will be important for cell recovery. I don't think megadoses, and again, they can be unsafe, should be used. The only other thing I would add is sources of selenium might be helpful. You don't need to take it as a supplement naturally, or you can get it, in foods that have it naturally, Do I think in and of itself or any of those vitamins I mentioned are going to help you recover from myelosuppression that's caused by chemo? Probably not. They can act like a crutch to get you over the last little bit, maybe, but there are other ways to manage it. And you, again, should discuss it with your oncologist.
Okay. Someone asked about 2-DG, 2-deoxy-D-glucose. I've never heard of that one.
2DG. Let me think. Did they ask for the context? It's just a supplement?
I believe it's an off-label.
Okay. Um, I wouldn't use I have not had a great deal of experience with 2DG. I think that if you're looking to rate limit your blood glucose and engage in that Warburg phenomenon and therefore use 2DG to like a way of getting a tumor in a metabolic trap, if you will, and engaging in that energy starvation. I don't think there's enough data on that peculiar molecule. And again, I go back to like what you want to do for who you are is probably get a glucometer, which, $40, and try to get your blood glucose about 100 or lower, not too low, right? But
Mm,
most of the time, again, I don't have a great deal of data to say that, but most of the people who I know who are experts in that area would say that's important. So do you need to use something like, 2DG? I don't think you need to. And again, whether you can use it as one day a pet and a pet tracer and imaging tracer and a therapy at the same time. I'm not overly familiar or enough familiar to say.
okay. Any advice on detoxing or I guess supporting your system while receiving Avastin?
Ooh, so again, that would be contextualized if you're on Avastin, one time every few months or regularly is gonna come with different advice and of course what other medical problems you may suffer from, like high blood pressure. Uh, I think endothelial health, your blood vessel health is going to be important with Avastin. And so, again, making sure you're getting a well-rounded, multicolored diet, if you will, all colors of the rainbow as many times as you can, and in variety as well. You're probably going to pick up most of the vitamins and minerals that are important. Beyond that, I think supplementation with a multivitamin and probably omega-3s while you're on Avastin is probably helpful for vascular health.
Okay, and then I'm just going to go through a few things quickly, and you don't have to speak extensively on these, but people are asking apricot kernels.
Oh, unfamiliar to be honest with you.
Okay,
Not
I'll
sure.
just keep
Yeah,
going if you're
yeah, go
unfamiliar.
ahead.
Soursop tea.
Ooh, again, for particular tea, I'm not familiar. Tea has lots of antioxidants in it. I would say historically green tea and black tea are better for you, but I don't know much about summer stuff.
Okay, and this one is a repurposed med, valganciclovir,
Yeah. So
Valtrex
they,
valsate. Yeah.
yep, yep. Antivirals are weak DNA damaging agents. And so uh, much has been lost in the literature about the, potential for antiviral component and very, 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 very muddy literature about, whether chickenpox are protective if you had it as a child, or vaccine strategies and what have you. So my take on that is you should do what makes sense. So adding valacyclovir to another DNA damaging agent doesn't make sense because you're just going to give yourself low blood counts, almost assuredly. Using valacyclovir instead of other DNA damaging agents that we know get into the blood-brain barrier is probably not a good idea. Getting vaccinated for shingles is a good idea because you don't want shingles. And if it is protective against brain tumors, great. But I don't have proof yet.
Okay. I'll try to wrap it up because we've gone on for quite a while. But somebody asked if you're taking new patients.
Always, always welcome to contact us. Yes.
Okay. And then I guess I'll close it out with what do you think are the best new promising treatments that are on the horizon?
Oh, I think two ways the field will advance are um, by kind of seeing, one is by seeing what we've seen thus far, which I'll explain, and then another is intratumoral delivery. So you've seen GBM sort of subsectioned into different kinds of tumors, whether it's GBM with BRAF alteration or an NTRK fusion, which have commercial available therapies beyond Temodar, uh, and or H3K27 mutants or IDH mutant tumors, right? These were all lumped in, so to speak, once upon a time when grade 4. So you've seen the pie getting sliced, small slices anyway, where there's more than glimmers of hope. And what I hope to find is more of the same. So drugs out there like PRMT5 inhibitors that work in MTAP deleted tumors, which are often in the setting of homozygous of CDK deletions. That is what there's like 8 drug companies working on PMRT5 inhibitors. So that I think is of significant interest. Um, Beyond that, I think taking drugs that mechanistically make sense, meaning you're going to divide into 2 camps. One, you have an agent that you might think may have broad applicability, right? You don't need a biomarker. It might be another DNA damaging agent that if you can help get into the brain through intratumoral delivery, whether convection enhanced delivery or ultrasound, then that might be helpful as those types of tech also complement the drug delivery. But
Mhm.
more specifically, if you have something that works on a specific subtype, having that biomarker-driven approach is going to be important. Um, and yeah, beyond that, you never know. There's always promise with immunotherapy.
Okay, okay. Any combination therapies? Like, there's the big Optune Keytruda trial that's ongoing now.
Yeah, I think, for something like that, it looks like I'm frozen, so hopefully you can still.
We can still hear you.
Okay. I'm at work, so UCSF didn't pay their internet bill. Um, I educate patients that the field in general needs to move to where instead of taking shots on goal approach by combining things that are available, we need a refined shots on goal approach. Where should I take the shot? How should I take the shot? In what subpopulation does this make the most amount of sense? And that applies to immunotherapy as well. What immunophenotype? What can I measure in blood? What can I measure in tumor that makes me think that you're more likely to derive benefit? Kind of like the MTAP and PRMT5 relationship. That biomarker enriched strategy is the name of the game for the future. Whether combos or single agents, you need that strategy likely to get more than just a chance of improvement.
Okay, and I am going to squeeze in just one last
Yeah,
question
yeah,
that
go ahead.
just came in because it's kind of a unique case. So there's a patient who's been on Keytruda since 2023. So any advice for integrative support while on Keytruda?
Ooh, it would depend on what symptoms, if any, that patient's having, right? And if you're on chronic immunotherapy for that long, and having benefit, I'd say you need to discuss with your physician, what do you think that end game is for how long you need to be on it? I don't have an answer for you without knowing more details.
Okay.
You obviously, or maybe not so obviously, want to potentially stay away from anything that might be immunosuppressive in your diet or supplements or what have you, right? So some of those herbs and things like that can suppress the immune system. Um, but yeah, that's a more nuanced answer to really dependent on that particular individual's case.
Okay. All right. Well, thank you so much for this very comprehensive presentation and for your generosity and time in answering all these questions. We really appreciate it.
My pleasure. My pleasure.
Thank you. That was very good.
All
Good
right.
night.
Thanks. Good
Take
night,
care,
everyone.
guys. Good night.